Federal officials are tracking an outbreak of bird flu in dairy cattle. It's been detected in herds in at least half a dozen states, which scientists are watching because they're alert for any potential pandemic. NPR's Will Stone reports.
Cows are just the latest mammal to end up with this kind of bird flu. There have been red foxes in the Netherlands, sea lions in South America, bears in Canada, and dozens more. Avian influenza generally does not spread well between mammals. One reason it's appearing more often now is probably because the outbreak is so huge. Millions of wild and domestic birds have been infected around the world.
I'm Carmen Twillie Ambar, president of Oberlin College and Conservatory. Welcome to Running to the Noise, where I speak with all sorts of folks who are tackling our toughest problems and working to spark positive change around the world. Because here at Oberlin, we don't shy away from the challenging situations that threaten to divide us. We run towards them. Since joining the Centers for Disease Control and Prevention in 1998, Dr. Timothy Uyeki has been on the front lines of global health, tackling everything from seasonal flu outbreaks to the high-stakes challenges of pandemic preparedness. He's played a key role in responding to some of the world's most dangerous outbreaks, including Ebola and avian influenza, better known as H5N1. Doctors like Tim Uyeki and his colleagues may never have the recognition of movie stars or athletes, but they are the true heroes of our society, working tirelessly and risking their lives to protect us from threats that could devastate entire populations. As the chief medical officer of the Influenza Division at the CDC, Dr. Uyeki and his team are the nation's first line of defense against an influenza pandemic. They live with the specter of the 1918 flu pandemic, which killed between 20 million and 50 million people globally and 500,000 people in the U.S. alone. Dr. Uyeki's path to becoming one of the foremost experts on influenza was anything but ordinary. Picture this. At Oberlin College, he spent his days studying biology and environmental ecology, and cold, snowy evenings playing blues harmonica with friends. From those early beginnings, he developed a passion for science and public health that propelled him to a remarkable career dedicated to battling some of the planet's deadliest diseases. Get ready for a deep dive into the world of the flu hunters and the vital work they do to keep us all safe. I spoke with Dr. Uyeki in late September during his visit to campus to speak with students and faculty. Our conversation touched on the current outbreak of H5N1 bird flu in the U.S. Since that recording, the number of cases has climbed, but the risk to the general public remains low, says Dr. Uyeki, and there's no indication of an emerging influenza pandemic. You can find links to updated data in our show notes. I'm so excited to have Dr. Tim Uyeki here on our campus. Welcome, Tim. How are you doing?
Thanks so much. Oh, I'm doing great. It's so wonderful to be back in Oberlin.
That warms my heart. I know that you have been working on the avian influenza, and I'm wondering if you could help us understand what is happening with respect to avian flu in this country.
This particular virus that's a huge amount of focus is this H5N1 virus. And this is a virus that is a highly pathogenic virus, which means that it has the ability to cause high mortality in infected poultry.
Okay.
And this virus is spread by wild birds. It spills over into poultry. And there's been a dramatic spread over the last couple of years around the world. And then what's been really interesting is it's spilled over to different animal species, so non-poultry animals, so many different mammals, ranging from very, very small mammals all the way up to a polar bear, to a Kodiak brown bear, to dogs and cats, to raccoons, to foxes, and so forth. But the biggest development in 2024 that really has just been observed in the US is that this virus has moved from wild birds or from poultry to infect dairy cows in the US.
Okay.
And in my career, I never would have imagined that an avian influenza A virus would establish itself in a cow. And the reason why this is important for those of us who work on influenza is if this virus gets well established in cows, which is a mammal, and has the ability to spread and changes, this virus might develop the ability to transmit to people more easily and then go from person to person more easily. So we're rather concerned when these viruses get established in a mammalian host, not just an avian or bird host.
Right. So that is a signal to you. When it transfers into a mammal, it heightens your concern about the transferability to humans.
Absolutely. And we have had human infections due to exposure to infected dairy cows in the US. They've all been clinically mild, but it raises concern because clearly the virus has the ability to go from cow to human. It just hasn't shown the ability to go human, to keep going. That's a good thing. And it may never, and we just really don't know. But what this situation has a profound agricultural impact upon the dairy industry and the poultry industry. So this virus causes high mortality in poultry, essentially wipes them out.
And how long a period of time?
In about 48 hours, you'll see about 95% to 100% mortality in infected chicken flocks.
Wow. So a poultry farmer could have his or her stock fully there, and then 24 hours later, the whole stock of poultry is gone.
They're either going to die or the remaining survivors will be killed to control the spread.
Wow.
And then there's an issue of decontamination, disposal of the carcasses. And then at some point when you've decontaminated, then poultry can be repopulated. So it's a short-term economic impact. But the dairy cow situation is fascinating because the dairy cows don't get sick and die. They get mildly ill or they don't get ill at all. And the major sign of infection in these dairy cows is they stop eating, and as they get dehydrated and they stop producing milk. And so for the farm owner, it's a loss of dairy milk production, but the cows tend to recover in about 2 to 4 weeks. And so it's a temporary economic loss of milk production.
Right. So I'm imagining that you all are counting on farm owners to report various things so that you can discover what's happening. And the incentive would be really different, I think, if you're a poultry farmer and your entire stock is killed versus milk producing cows where it's 2 to 4 weeks. And you may or may not, I think maybe as a farmer, actually know what's going on.
That's absolutely right. Everything is about economics. If you report and if you start testing your dairy cows and you find this virus, and this virus is heavily concentrated in the milk, you do not want this raw milk to get into the milk supply, even though pasteurization will inactivate this virus. Pasteurized milk is safe.
Okay.
But there is somewhat of a disincentive to actually finding out that your cattle are infected, because unless you're going to be reimbursed for your temporary economic losses, you are in some sense self-penalizing.
Right. To go and report this and tell somebody that something's going on.
That's right. But now the U.S. Department of Agriculture does have reimbursement programs. And so that is a real positive thing for these farm owners and for the industry. So we have worked well with the poultry industry over a number of years. We have also worked very well with the swine industry. But this whole dairy cattle transmission, this is new. This just is discovered in the US this year. It's ongoing. 14 states now, as of late September, have reported 213 confirmed dairy cattle herds in the US.
Right.
And there probably are more that haven't been tested or the reporting hasn't been done. So it may be an underestimate. But this is a new industry that we're trying to work with in terms of public health. And it takes time to really establish trust, to be able to share information, to do joint investigations. And now it's working better. in some states than in others, and it's certainly working better than it was 5-6 months ago.
Public health professionals are yelling and screaming about 4 or 5 cases where the humans they aren't really that sick, but you want me to shut down my whole farm and do all these things that are really financially impacting. So this notion of kind of creating this one approach where all of these professionals are working together, but the incentives are complicated.
It's a very challenging situation. So this year in the United States, we've identified 14 human cases to date.
Okay.
That means there have been 4 cases in dairy farm workers, and there have been 10 cases in others, and 9 of those were in poultry workers.
Okay.
They all had very mild symptoms. They were not hospitalized. Almost all of them were treated with an antiviral medication called oseltamivir.
Okay.
And they all recovered and they're fine. And so from one perspective, you might say, hey,
what's the big deal?
What's the big deal at all? This is public health is crying about this, but these are people who didn't have severe disease. So
mild cases. What's the problem? Why are you yelling and screaming, Tim?
Absolutely right. So here's the perspective from those of us that work on influenza globally. A historic perspective, and that is since 1997, this virus has spread mainly from poultry to people. As of today, since 1997, it's about 929 human cases reported from 24 countries, and about 50% have died. And there are people in other countries in 2024 who have acquired the same virus infection. It's a slightly different genetic variant than the virus going around in the US in poultry and in cows.
Okay.
But it is the same virus, and it has caused critical illness and death in people in Cambodia this year, generally poor rural villagers.
It seems like you shouldn't worry, but we need you all to worry, because in that worry, it allows you to be trying to think ahead of what the potential devastating outcomes could be that we all now have a better sense of because we've experienced COVID-19.
Absolutely. And it's for people like myself to worry about. It's not for the general public.
Right.
So we say right now, the threat from this H5N1 virus to the general public is very low. There's certain occupations or occupational exposures that place people at higher risk. But for the rest of us who are not exposed to dairy cattle, to sick or dead poultry that are infected, we shouldn't worry about that. Let some people like myself worry about that. And we'll let you know when you should be concerned and it's time to take precautions.
Good.
The time is not now. Good,
because I don't know if I can add anything else to be worried about, Tim, honestly. I think a lot of people feel that way. But I'm wondering, the pandemic, the COVID-19 pandemic obviously changed the world's perspective about viruses and the ability to sort of stop the world because of a pandemic. And I'm wondering whether people pay more attention to the flu now. You know, in the past, you would sort of, yeah, it's the flu, and we know people died from it, but we didn't have a heightened sense of it. I'm wondering whether you feel like because of the pandemic, people pay more attention to your work, or maybe they pay less attention to it because it's like, it's not COVID-19, so what are we talking about?
I think a lot of the public, and I refer to the US public, but I think it's worldwide. I think a lot of people are just, I'm done. I'm over COVID-19. I don't want to hear about it. But in fact, the virus that causes the disease we refer to as COVID-19, SARS-CoV-2, it has not gone away. It's an evolving virus, hence the need to update the vaccines.
Right.
These viruses are always evolving to try to escape immunity that people have, either from prior infection or from vaccination or both. I think a lot of this sort of perception or people are tired of COVID-19 has spilled over to we don't want to hear about influenza either. And we don't want to hear about vaccines. So what's happened is COVID-19 vaccine coverage has dropped off, even for high-risk people.
Even people for whom we had the most concern during the early stages of the pandemic.
For some high-risk groups, it's okay, but for most high-risk groups, it has dropped off. It's lower than it has been in prior years, It's certainly not to the level of what we would recommend.
Right.
And the same thing has happened with influenza vaccines, that this has dropped off, including in high-risk groups. And so there's been an unfortunate effect of a decrease of vaccination in general, and that's true of routine childhood vaccinations. We're seeing outbreaks of vaccine-preventable infectious diseases because of the drop-off in routine vaccination coverage. And for example, there are measles outbreaks in the U.S. right now. Measles is a vaccine-preventable illness. Very highly effective vaccines. This remains a challenge, and some of this is a function of what has happened during the COVID-19
just
pandemic.
Sort of fatigue in general around vaccines and talking about this. But I'm also wondering what you would say about this kind of decline in people's valuing of expertise and how we communicate, or how people perceive the communications from public health professionals.
It's a real challenge. And who is an expert? What is an expert? Who do you trust? And I think that some of it is our fault in public health, and some of it is way beyond our control.
Let's talk about both. What do you think public health professionals could do differently? And then what do you think are influences that you don't have much control over?
I think some things that we could have done better during the COVID-19 pandemic is to say, hey, here's what we know right now based upon the data. Here's what our recommendations are. These are what we would term interim recommendations. They're based upon our current understanding of the situation, but realize we're looking for new information. There's a lot of unanswered questions, a lot of things we don't understand. And so as we get more information, more data, our recommendations may change a lot. And so I think we haven't done as good a message, or if we have done that, it hasn't been heard.
I'm thinking about my own experience being president of Oberlin and helping our campus through this pandemic. And there were moments where people express frustration with public health professionals and even use terms like they lied to us or they misled us. Those of us who are on these sort of academic campus know that things change. You know what you know at this moment. You get more information, and then it alters the way you would advise people. But not helping the public know that that was possible, I think, hurt the credibility of these incredibly wonderful public health professionals.
Completely agree. And what we saw throughout the pandemic was criticism, harsh criticism of public health officials, people who didn't agree with their recommendations. And it was personal attacks. And even people showing up at the home of public health leaders. People were burned out. And when they're being threatened, it's too much. So there were a lot of key public health people, including in Ohio, who just said, that's it, I've had enough, I quit.
Absolutely. I remember that vividly. This got politicized in a way that became polarizing, and people of different parties and different perspectives were weighing in on public health recommendations from a political perspective, which then led to people behaving like they were in a political campaign as opposed to a public health crisis.
And I think we just have to realize that there is so much disinformation out there. We need to track it. Why is it that you're anti-vaccine? Why is it you're anti-mask? And we can't just make it as we against them or them against us. We have to actually work together with everyone. If we don't understand where they're getting this information or have acquired and integrated these probably different ways of thinking about these problems, then we're not going to win. And I think you have to show people respect. You have to listen to their opinion. You have to gently try to educate them in different ways. And I think we just really need to do much better. And at CDC, we have people that work on how to translate our webpage information down into a short podcast, into a webinar, into tweets. Very frequently, I am reviewing draft tweets that are going to go out for social messaging.
Never thought you'd be doing that when you were graduating here from Oberlin. Part of your role would be reviewing these only 140 character messages out to the community to understand public health.
I come from the days where there was no email. So this is caveman, cave person, pre-technology days.
Yeah, it reminds me of what's so powerful about the opportunity for students, particularly here at Oberlin, to have this interdisciplinary education, because you have been helping us think about global public health as a major. We're just launching this year a communications major. And it's the intersection for that student who has a really strong science background but wants to be a communications professional. And I'm sure that you have lots of people like that at the CDC whose sole job it is to take this scientific, important information that the public needs to have and put it in a way that the public can digest it. And that's on Instagram, I'm sure, and tweets and all those ways, because if we can't understand what you're saying, we cannot adopt your recommendations.
I couldn't agree more. And I think it's what's needed for these students to be successful in their careers and to function in the world to come.
I find this generation of students really interested in trying to tackle these intractable problems of the world that have all sorts of elements to it. Like they may have a scientific element, an anthropological element, an economic element. Like they know they need all those things to come together in order to be able to think about them effectively. And so they're asking us for this interdisciplinary approach, right? They know they need communications. They know they need some technical background in econometrics or mathematics. They know they need some great science courses. They can't do that and tackle the types of things that you are tackling without all of those skills. The world is small. This is the global issue, not a U.S. issue. And I'm wondering what you think about the global community's willingness to share information. Like one of the things that I hear people complain about when they think about the pandemic, they still talk about where did it originate from? Did we get the right information from other countries? You're talking about the challenges of just communicating in this country. What can you say to us about how we do that globally?
It's all about partnerships and it's all about trust. And this does not happen in a day or a week or a month, but it's long-term relationships. And so you need to establish these working relationships. These are collaborations. These are not we're helping you. It's we're working together with you. Until there's mutual trust, there's not going to be sharing of information, because I think there has to be a recognition that there's mutual benefit to working together,
right,
and to sharing this information.
Do you think we're getting better, or do you have concerns about our ability to cooperate globally around these very impacting viruses?
Unfortunately, there are international politics that inhibit some good collaborations, and those are much more challenging because they deal with not just health security, but national security issues. One of the issues is sorting out what's accurate information and what is false information or what is disinformation, and then trying to interpret that and figure out how to respond. I've worked with people in other countries for decades, and so we've built up trust and we have free sharing. But that may be different on an individual level than from the national level to the national level. Yeah. But it's not a short-term issue. It's got to be a long-term approach to build that trust.
I guess I wanted to switch gears a little bit. Maybe you can help us know how you got into I don't know what phrase you use, maybe the disease detection business, for lack of a better term. Like, how did you get to this work?
So I am one of these people, I would describe myself as an oddball. I have had a strange pathway. I guess it's sort of zigzagged here and there. And so before I came to CDC and worked in epidemiology, I got a master's in public policy degree from the University of California, Berkeley. And then I went to medical school. I trained in pediatrics, and I also did another residency, which is called preventive medicine. And I got my master's public health degree through that. And then I worked as a clinician for 5 years. And I came to CDC through this program called the Epidemic Intelligence Service Program, or EIS program.
Interesting.
And this is an applied epidemiology fellowship program Not everyone is a physician. There's PhDs, there's nurses. Occasionally there's a lawyer or two. You spend 2 years at CDC and you learn applied epidemiology. That's how I came to CDC. But if you're at CDC, you have the opportunity to work on many kinds of outbreaks. And of course, if they're global outbreaks, then we all get pulled in.
Well, tell us how that works, because I know, you've been to at least 15 countries, worked on all sorts of outbreaks. Give us an example of how you get pulled in and end up at the epicenter of Ebola. For those of us who don't know about this world, tell us what that looks like.
In 2000, right after I finished the EIS program at CDC, there was an outbreak in northern Uganda.
Yes.
It's now the third largest Ebola outbreak ever.
Oh, wow.
I believe
I remember when that happened.
CDC sent different teams to work with the World Health Organization. And I volunteered, and it was fascinating. I learned a ton about field work, about working in sub-Saharan Africa, and a lot about Ebola.
Just so we get a little re-education, help us understand exactly what Ebola is.
So Ebola virus is a family of viruses that we label as viral hemorrhagic fever. It can cause a very severe and critical illness with high mortality.
Okay.
These viruses are generally circulating in animals. And it's only when there is spillover to humans,
right,
in which it comes to the attention of public health. It's when we have these outbreaks. And we've had these outbreaks typically in West Africa, Central Africa.
That's my recollection.
Some in East Africa. But this virus is typically transmitted through direct contact with bodily fluids. It's typically not transmitted through the air. And in people who are very sick with Ebola, the virus is concentrated in the skin, in the epidermis. It is infecting multi-organs, and it's definitely in the blood and in bodily fluids. But if you don't have close contact with these patients, then you're not at risk.
Right.
So we know how it's transmitted and we know how to prevent and control it, but it's typical that these outbreaks occur in remote settings.
Right.
So one thing is to get patients isolated, get them away from the community, reduce transmission,
right,
get them in an Ebola treatment unit, but also try to save them. It sounds like a real threat to people, and there was a lot of anxiety in the US, but
yes,
this
I
is
remember
not
that.
a virus that poses a risk to the general public. It's you really have to have that direct contact with bodily fluid. It's really trying to dispel some myths and disinformation and really educate what is the risk, what is this virus, how is it transmitted, clearly to really reduce the level of anxiety in the US.
Yes, I remember that time period and how much anxiety was created. And I think that some of people's kind of latent issues around race played a part as well. We saw that happening in the pandemic too, when people were thinking about the origins of COVID-19. One of the things that I think all of us saw through the pandemic was a deeper appreciation for the toll that this type of work can take on healthcare providers, on people who are part of the caregiving community, on researchers, on all the people who are being really exposed to this loss of life on a large scale. I've read and know that sometimes you have to do things as difficult as taking samples from corpses. I was going to ask you whether you were ever concerned about your own safety, how do you square that with this desire to go and get engaged?
Well, one of the activities we did was if someone dies and there's a concern that Ebola virus infection might have been the cause, then we need to know whether that person died from Ebola or not, because the close contacts need to be followed for 21 days. So it has a lot of implications for tracking the spread of this virus. So it's really important to identify as many confirmed cases as possible. And the best specimens for identifying Ebola virus in someone who has died is a blood specimen. When someone dies, blood starts clotting. The only real source, a serum specimen, frankly, is doing a heart puncture. In medical-ese, we say cardiac puncture, right? And so you just protect yourself and you wear as much personal protective equipment as possible.
Right.
And you're extremely careful. It's probably the most intense concentration that I have ever done in a long time. But if you're trained well enough and you have the experience and you know what you're doing, then you can do it safely. I think any of us who do it, we're a little bit apprehensive about it.
Right.
And it's very unpleasant. It's not something that you ever want to do.
Right.
But it's all part of the work that's needed for surveillance purposes. And so you just do it. And you take risks, but you do what you can to minimize the risks.
How do you sustain yourself when you are dealing with this level of tragedy?
It's a real challenge, but having had the experience of taking care of very sick patients and unfortunately having patients die, it's something that you never get over. On the other hand, you have to keep moving forward. And what keeps me going is really collaborating with a lot of people all over the world. And that means a lot of people outside CDC, throughout the US, and then people in other countries. And probably the most stimulating for me is when I'm working on problems and collaborating with people far from Atlanta. It's really hard to answer that question, but having been lucky to have worked on a number of sort of urgent public health problems and going through the stress, you kind of know what to expect, although every situation is unpredictable.
For the audience, you've worked on SARS, Ebola, influenza, obviously, some of the most deadly and difficult public health crises that the world has experienced.
Well, someone's got to do it. And I have some experiences and probably some skills that I feel I can contribute. And I can recall back September 11th in the US, and it was rather devastating. And we were all worrying about a potential bioterrorism attack and even thinking about, could there be a smallpox release? Ended up being, unfortunately, a lot of white powder was sent to major media companies. We had, unfortunately, some postal workers that died of inhalation anthrax. But I can remember, because of the tragedies of 9/11 and because of the concern about bioterrorism, I remember getting a phone call and saying, we'll give you 30 minutes to respond. You can't tell anyone. We're assembling a secretive group to prepare for a potential smallpox attack.
Wow.
Your name came up and we wanted to know if you will join. And I sort of got pretty stressed about that. But then I thought, somebody's got to do it. And so I called back and said, yes, I'm going to volunteer.
Wow.
Over the years, when these kinds of events come up, I tend to volunteer because I've worked in different countries, all levels of public health, all levels of the World Health Organization. I've been in the field. I enjoy that work. Is it stressful? It's incredibly stressful because...
It sounds stressful, and I'm not doing it.
But I just sort of feel like, hey, I want to help. And I don't know if I can pinpoint where that comes from, if it comes from just this social responsibility, this commitment, whether one could say, oh, it's comes from Oberlin College. I don't know. I just like helping in those kinds of emergencies. And when the situation comes,
you answer the call.
I try to answer the call. And it's those kind of collaborations. And sometimes, it's 10 years later, hey, I work with you in this country. I work with you on this project. And here we are working again together side by side in this. And that has actually happened. And so the world is a lot smaller than we think. And so that's kind of invigorating and rewarding, actually.
The world's a lot smaller than we think, and the world's a lot safer than we know because of the work that you do. You already answered what my question was going to be. So this audience knows the title of this podcast, Running to the Noise, we got from Michelle Obama's commencement address here at Oberlin. And so I always ask the participants on this podcast, how do they run to the noise? But I think you just answered it, Tim. And I guess what makes me so thankful about it is that all of us need images to look to know that what we want to achieve is possible. I'm so glad you had a chance to speak to our students today, because they're looking for a way to make the world be better. They're looking for a way to have impact. And they're looking for people like you who they can say, Tim did it and he started here at Oberlin, so maybe I can do it because I'm here at Oberlin.
I think these students are going to go do great things. And I said to them, there's so many public health problems that my generation has created and your parents' generation has created. And you need to go out and address and fix those problems. And if just one of those students does that to contribute in some way, then it was great that I was able to maybe discuss that with that student. I just want to put a plug in for 2 Oberlin alumni.
Okay.
Keiji Fukuda.
Yes.
And Tom Frieden.
Yes.
And Keiji was my supervisor when I came to CDC.
Right.
He's still a close friend. And Keiji was an assistant director at the World Health Organization. So
Right.
he was a leader at the global level.
Right. He graduated in 77 for those of you who don't know. He that was the year he graduated from Oberlin.
And another very prominent alumnus is Tom Frieden.
Yes.
And Tom was a year behind me at Oberlin. And he was the CDC director for quite a few years.
Yes.
And he's now the head of Resolve to Save Lives. So he continues to work globally. And so I'm a little embarrassed that I'm the guest on this podcast. I mean, I feel very fortunate to have the privilege of talking to you, President Ambar, to have been able to meet you again.
Yes.
Now it's about my 3rd or 4th time
That's
to have
right.
met you again.
I'll say to the audience, I think Tim's diminished himself a little bit, but I will say that one of the reasons why we have been focused on global public health as an area to really sort of highlight is because we have had so much success in having our alumni in this professional world and to achieve some significant heights. I think I jokingly said to you, Tim, when we were talking about your 2 colleagues, like what was in the water during that time? So the 70s, I think Tom's here in 82, you're a little bit in between them, but having that leadership at the CDC, all being OBs, I think says something about this institution and how we not only prepare students for leadership, but prepare them for going out and changing the world for good. It's the commitment to serve and to do something that you know can make a difference. And it's an admirable quality that we just so value because we know so much that as a society, people's willingness to sacrifice for the good of the whole is something that is rarer than we want it to be. And so I appreciate that work and service and willingness to go and do the difficult things so the rest of us can be safe.
It's all part of the job. Someone has to do it. And it's invigorating to work with people from other countries who are equally committed.
You've been saying a couple of times through our conversation, Tim, that someone has to do it. Someone has to do it, but some people choose to do it, and you have chosen to do it. That's one of the things that makes you really special.
I really appreciate it.
Thanks for listening to Running to the Noise, a podcast produced by Oberlin College and Conservatory. Our music is composed by Professor of Jazz Guitar Bobby Ferraza and performed by the Oberlin Sonny Rollins Jazz Ensemble, a student group created through the support of the legendary jazz musician. If you enjoyed the show, be sure to hit that subscribe button, leave us a review, and share this episode online so OBs and other folks can find us too. I'm Carmen Twillie Ambar, and I'll be back soon with more great conversations from thought leaders on and off our campus.